Hey everybody, welcome to Thursday, the fifth week of this stay-at-home stuff. As you can see, I need a haircut, gaining weight, getting old. It's been a wonderful time. So what I'm going to go over today is robotics. So if you'll bear with me a minute, I'm going to put up the PowerPoint and I'm going to go over robotics first, and then I'll go over the robotic instrumentation for you. So hang on. Okay, so hopefully you're all getting this. Hopefully you see it. We're going to do robotic assisted surgery. We're going to do basically that. Shouldn't be too long. Okay, let me use this down. All right. So what we're going to talk about are the principles of robotic surgery. We're going to talk about robotic movements and classification. We're going to discuss the training resources for robotics. So if you're looking at this, it looks a lot like those text review questions in the text book. So we're going to talk about three main components of the robotic surgery. That is actually also on your final lab check off for this semester, or for this class, I'm sorry. So you might want to look at that and learn those. And you're going to describe their function and describe the roles of team members during robotic surgery. So first of all, let's talk about the principles of robotics. Basically, robotics combines the techniques of minimally invasive surgery with computer-guided instruments, okay? Robotic, again, is a mechanical device programmed to perform a task, and it's usually minimally invasive with computer guidance. I did put a picture here of the Versius surgical robotic system, which is different than the Da Vinci. This one you'll find in Europe, but it's coming over this way too. So there's a couple different types of robots you could be using, okay? Right, so let's talk about robotic movement quickly, since it's kind of boring. Surgical robot system movements closely resemble the actions of the human body, allowing the arm to move up, down, side to side, and back and forth. That's the difference between using a robot and just doing minimally invasive. Minimally invasive, you're really reduced at how much movement you can have, whereas with robot, it's just like a wrist. So the robotic arms are just like a wrist, if you'll remember that, okay? Robotic movement is enabled by articulated sections, Cartesian coordinate geometry, which is that picture right there. So if you did take geometry, you should understand where Cartesian coordinate geometry is. And if you don't know it, look it up. It's in the book. Okay, I'm not going to go over it here. Spatial dimensions and degree of rotation is very important also. Classifications of robots. You get different types of robots, and I put two different ones here. There's that Versius and there's the Da Vinci, okay? We used to have one called the ASOP, which was just an arm that we'd hook onto the bed for the minimally invasive surgery. It would hold the camera. There used to be a Zeus robot, which of course they don't use anymore. So a couple things you need to understand. Their design is one difference, determines types of movements and their reaching space. So what actual space where do they move? One thing you need to understand is servo-controlled robots and non-servo controlled robots. So make sure you mark this down. Servo robot responds through its sensors, whereas a non-servo robot has no feedback or sensing abilities, okay? So these two robots are servo robots, okay? A non-servo robot is one that has no feedback or sensing at all. It just does the work, okay? The Da Vinci system is the one surgical robot system in the United States that's approved for telesurgery. The other one you see here, the Versius or whatever, it isn't approved yet, but it's on its way to being approved. One thing you need to understand is what we call telesurgery, okay? Telesurgery is where instruments are inserted manually or with electric assistance, but are controlled through a remote, non-sterile console near the sterile field. So with Da Vinci, and we'll talk about the console in a minute, the console is one part of the room, and then the cart is somewhere else with the arms on it. So that's considered telesurgery. Also, telesurgery can be if it's by phone or by video, okay? where it can be worked through from another location to that particular hospital. Some advances that we've had in robotic surgery that we didn't have before. Our images are 3-dimensional, and they're actually got a 4-dimensional one now. I don't know what that would be, but I saw that recently, okay? So images are 3-dimensional with robotic surgery, where they're 2-dimensional with regular minimally invasive. The robot reduces tremor and movement scale, so if the doctor has a tremor or a twitch, it takes that out. So the instrument isn't going to move to include his twitches. It's going to take it out, okay? And they closely replicate human movement, meaning it's just like a wrist, like I told you earlier. Robotic surgery allows greater depth perception and increased precision over traditional minimally invasive surgery. That's why robotics has become so popular. Some disadvantages, and these are kind of starting to go away, but it can be expensive and uses valuable resources. Requires on-site coordinator. Every hospital that uses a robot usually has a person that's in charge of the robot itself, okay? And surgeons have to receive training, and I'm sure you've seen movies and things about that, but they should receive pretty intense training on how to use the robot, okay? We talked about haptic feedback a little long ago. Let's talk about it again, because haptic feedback comes in play here. And if you remember haptic feedback, that's sensing the sense. So with this, what does the absence of haptic feedback mean for surgeons being retrained on remote instrument manipulation? So what it is during robotic telesurgery, the surgeon must rely on vision alone while manipulating the hand and foot controller. So you're still missing that haptic feedback, but some new, the newer robots they're developing now, some of them are actually starting to see if they could add that haptic feedback to the robot, okay? Robotic training. All members of the surgical team must receive special training, and that includes a surgical tech. And training for the Da Vinci system is usually available from the manufacturer at various locations. So the Intuitive is the name of the company that makes the Da Vinci. They would come out. They just happen to have an Intuitive office here in this area, and they come out and train, usually set up training courses. So with robotic training, you have system preparation and management, inanimate labs for skills development, which is what the picture is I'm showing you here. Procedure training, rehearsals, and a video podcast you can do for robotic training, okay? Additional resources. A lot of places have in-service programs. If we would have been on campus, we would have been in, this wouldn't have happened. We were going to go to Swedish and be trained on the Da Vinci there, but unfortunately that couldn't happen. So when you get back to the school, we'll show you the other robot and show you how we drape it and so on and so forth. In-service program with manufacturers' representatives can happen. That's very hard to get unless you work at a hospital and they bought a so many $1 million robot. I've been trying for 5 years and haven't been able to get someone to come. Role observations, rehearsals, supervised practice, and mentoring feedback. The surgical tech should have access to both on-site and off-site learning opportunities. And Friday, you will be watching a video on Da Vinci robot, so that'll kind of give you some ideas too. And then continuing education is critical as the technology is modified and refined. And it is. You'll see a huge difference between the XI, which is the one you see in the picture there, and the one that we have at the school. Okay. Surgical specialties in robotics. On this list, it has orthopedic, cardiovascular, general, gynecological, urological, and neurological. And it really started with urology, to be honest with you. The first thing they really did with the Da Vinci was prostatectomies. And then they started doing kidney removal. So It's really expanded now. We do just about every specialty has some kind of way, robot or way that they use. The picture I have here is robotically assisted total knee surgery with the Mako robotic arm. So that's a newer one. I think it's been around a few years, but I've never used that, so that's different. So some other procedures you could do other than joint replacement, valve repairs, lung resections, GI resections, removal of tumors, hysterectomies, myomectomies, sacral polypectomies, prostatectomies, cystectomies, tumor resections. They do hernia repairs. Now they're starting to do gallbladders. So they're doing a lot of stuff with robots. Some components. There's the 3 components right there. And I'll see if I can take my thing here. You have the patient cart, and that's the arms here. Okay. It can be called something else, and I think I have it in the instruments I'm going to show you, but its patient cart is right here. Surgeon console is right here, and the imaging system is here. So if I ask you to name the 3 parts, it should be the patient cart, surgeon console, imaging system. Okay. If we have time and I can get the console up, I can let you play with it and look at the 3D when you get back. Okay. And just so you understand that in robotic surgery, the surgeon is not scrubbed, as you can see here. He sits at the console and manipulates the instruments. The console is placed outside the sterile field, but close enough for effective communication between the surgeon and other team members. So rooms with robots are usually dedicated for the robots. So these consoles are put where it's convenient for the surgeon and the rest of the team. Okay. Instruments used in robots, and I'll go over those in a minute. Okay. And if you look at figure 22, 24 in your book, it gives you some of the various instruments, but they're similar, the same as minimally invasive. And there's a few different you're going to see, but they're same as minimally invasive and regular, just long and set up for a robot. So it can have a 360-degree wrist-like action in the ends. So you can have scissors, graspers, knife, probe, needle holder, ultrasonic energy instruments. Those are all part of robotic instrumentation, which I'll go over in a minute. Decontaminating and reprocessing robotic instruments. Unless you work in sterile processing, you probably won't see this, but it's still important for you to know that these instruments have a lifespan, and their lifespan is 10 uses. Okay, the old type of instruments, we actually had to take a Sharpie and mark a little line, just like you would on the side of a wall, until we reached 10, and then they were no good again. Okay, now they send them back to the manufacturer, and they refurbish them and reuse them if they want to. Okay, so some instruments have a lifespan, meaning they have a certain number of uses before they are not to be used again, and that is 10. It says in the book, usually this number is 10. It's always 10. It's never changed. These instruments should be sterilized between patients. Robotic instruments should be cleaned, disinfected, and sterilized according to specific protocols. And you have to do your IFUs through the manufacturer for that. There's also online resources that are excellent for providing info on reprocessing instruments, especially with the Da Vinci system. So that would be a help for you guys. Okay. Setup for robotic surgery. The room setup should optimize safety and communication. The robotic surgery equipment should be positioned in a manner that protects the field from contamination. Okay, so really what you're looking at is draping that robot correctly and making sure that console is far enough away so it's not going to be a hindrance. Nowadays, most of the equipment is on the booms for the robotic surgery, or it's on its own boom. Okay, that's why they keep the rooms set up just for robotics and have them dedicated for that. The operative setup must be planned so that anesthesia time is not used for tests that should take place before the surgery, like draping the robot and so on and so forth. Okay, so here it tells you sequence for robotic surgery. You adjust the components. The non-sterile connections are made, just like in minimally invasive. You're plugging everything in. Sterile setup is completed and the procedure begins. Okay. All right. And then I threw this in. It just kind of shows you a setup, okay, of how it's set up. And I think this setup is for a for a robotically assisted laparoscopic cholecystectomy. Okay. So you can see the surgeon at the console over here. They call it nurse. It should be surgical tech is over here. They have a vision card here. Ours are usually up. We usually have this one. And then, of course, if you've got a monitor on the wall, it comes on that one too. Okay. Right. So individual roles in a robotic surgery. This is where you guys might get a little messed up. You got the surgeon has his role, and his role is usually number one. When we begin robotic surgery, we start with minimally invasive surgery. We don't just pull the robot up first. We make a port, we look around, he checks to see if it's okay to use the robot and if it's going to work. If it is, then we pull, he moves back, takes his stuff off, and then we get set up for the robot. Okay. So he's at the console. Surgical assistant, and I'll read what it has here, but the surgical assistant is the one that usually puts the instruments in the arms and puts the arms into the trocars. Okay. Scrub tech is important because, first of all, he's going to be there for the minimally invasive part. He's got to help with that. Second of all, he or she has to have all the instruments and all the equipment that needs to be used in this case ready to be handed to the assistant to put into the cannulas. Okay. So in your book, it says the surgeon performs sterile techniques to place the trocars. That's the MIS. He or she then breaks scrub to operate from the surgeon console. Surgeon returns the sterile field near the close of the procedure to remove the trocars and close the incisions. Surgeon directs the flow of the procedure and is responsible for coordinating the activities of everyone on the team. The surgical assistant performs other specific tasks at the sterile field. It usually includes exchanging instruments on the sterile robotic arms, managing any instruments that are outside of the control of the robotic system. Then the assistant works closely with the scrub to maintain a clean, safe operative field. Instrument exchanges and management of the sterile robotic components are the dual responsibility of the tech and the assistant. So the surgical tech maintains the robotic instruments during surgery and assists or directs the draping procedures. After the cannulas have been placed, the scrub may direct the positioning of the patient cart. The scrub is familiar with the operation of all electronic and vision components, assisting in registration and white and black balance. He or she may also operate the clutch arms and at the close of surgery, help retract all the instruments. The circulator directs all the scrubbed and non-sterile staff during surgery. So that's the duties of all of these people. So you do play a good part as far as robotics. You don't just stand there like some people probably have told you, okay? Then there's some special roles of the surgical team. Components need to be positioned in a way that optimizes safety and communication among team members. So that's a big role for everybody, okay? Surgeon, surgical assistant, surgical tech, circulator, and robotics coordinator. Where I came from before I retired last year, the person that usually scrubbed robotic cases was the coordinator. So, because she was a tech, wasn't a nurse or anything. So that's something for you to remember, that you can be a coordinator as a tech. Okay. And if you have any questions, please email me. I haven't really gotten a whole lot of emails from anybody. And so if you don't understand something, please email me. Okay. All right. Okay, so let's move on to robotic instruments. Yeah, I look pretty bad, so I'm not letting you see me too much, and the cats are driving me nuts. So I'm trying to pause and do these. So you just see these. You don't see anything else. All right. So let's talk about the instruments, because you do have to make flashcards. Now, if you see that little chapter 5 there, that means those are the instruments in your chapter 5 of your instrument book. So those are the ones that you need to do your flashcards on. Now, one thing I will tell you right now, do not plagiarize this book. So all you really need to do on instrument flashcards is a picture of the instrument, and then on the other side, the name of the instrument. That's all I'm looking for. That's all, unless you want more, because these are for you to study for these tests. Okay. And I also have a robotic Kahoot, which I'll open up after all of this. Open up on Friday probably. And there's also the MIS is back up, and all the other things are back up. So for the robotic tests next week, you have those open, plus also for the midterm. So you should be able to, I've got all the Kahoots open for that midterm. Okay, so I digress back to robotic instruments. So Da Vinci is the one we talk about. So those are the instruments where you're going to go over. Okay, and all of this right here, you already understand because we just went over it. And I'll put these PowerPoints, by the way, on Blackboard for you. Okay. All right. Robotic equipment. Let's talk about that first. One thing I wanted to show you real quick is these are the different versions of the Da Vinci. Okay. This is the newest, the XI. This is the oldest. It's the Da Vinci. They call it first generation. Look, that's our robot. So see how many times it's changed. Okay, quite a bit. So, but they still function on the same principles. Okay. So here's the robotic equipment again. You've got your console, which is where the doctor sits, and there are all the parts of the console there. So this will be on, again, on Blackboard, so you can look at it. And then you've got your 3D HD video tower. Okay, and it's showing you each part of the tower. It's very similar to a tower for MIS, because you do have light sources and so on and so forth in here. There's your screen, your illuminator. It's got a different light source, just so you know, camera control, core, and tank holder. Remember, because if they get all the insufflation and stuff is right there, and then your camera assembly, which we'll show you. This is called a side card, or I think it's called a patient card. So on your checkoff or your test, if you put side cart, that's fine. If you put patient cart, that's fine. Okay, Da Vinci calls it a side cart. Your book calls it a patient cart. Okay, so here's a picture of the side cart with interactive control arms, and it shows the draping for the XI. It's a little different than the one we have in the office, but actually the draping is quite easy now, easier than it used to be. Okay, but I just wanted to make sure you saw the draping. Okay, all right. So the thing with the instruments, they're called endo wrists because they offer a full range of motion just like a human wrist. That's going to come up in the future, so you better remember that. It's like a human wrist. Okay, if you don't see wrist and it says it's like a human hand, then it's probably hand, but it's like a wrist. That's why it's called endo wrist. Okay. First thing we see here are, this is the Da Vinci first generation and Da Vinci S instruments. Okay, and that's what we have in the school. And then these are the Da Vinci XI instrumentation. See, they're a little bit different. They actually have one more control that makes it, they can do even more. Okay, and I do have these at the school if you need to look at them. So here we go with some of the instruments, and this is going to be a breeze, so it's going to be quick. Here's this cautery spatula, just like what you saw in minimally invasive. Okay, but you can see it's going to move a lot more. We have a Maryland bipolar, and this Maryland a little different because it has that hole, but it's still the same shape. Okay. This is a curved scissor. Okay, anyways, here are your curved scissors, like your endo shears. Again, they're the same. It's just you got more movements. Okay. Pot scissors, you didn't see those on the other ones, but they are angled, so that would be for vascular. Okay. You can just see with these instruments, it's a good picture because you can see how many movements they can make with those cables. And those are real teeny. Okay, here's a new one for you, the PK dissecting forceps. Okay, PK dissecting forceps. Look at this, learn it. okay, because they look like other things. You got a cobra grasper. It's not called a mother-in-law in here. It's called a cobra grasper. Kind of looks like one too. You got the DeBakey forceps. They're a little different. You see they're straight, but they are DeBakey in the mouth, okay? Rosano forceps. Again, Rosano, that's another one new for you guys. Look at the jaw. It's totally different, okay? The Progress forceps, another new one, Prograsp. See, it's a grasper, but it's open, okay? Arterial retractor, that would be for arteries and so on and so forth. So don't get into too much of that. And I don't even know if I've got one in the classroom, but we can look. Suture cut, again, another name. It's another name. You're going to have to put suture cut needle driver, not just needle driver, because there's another type of needle driver. So look really close at this part when you look at suture cut, okay? Large needle driver, there you go. It doesn't look that much different. Let me go back. That's the suture cut. See how flatter it is? That's the large. See, it's a little different in the jaws, okay? This is a Da Vinci endoscope. Now, I just put this in here because I want to make sure you see what the endoscope is like. And this is an XI, I believe. Okay, so it's a little bit different than ours, but they're pretty bulky. I'm just showing you how it's plugged in. This is the room setup and trocar placement. So I believe this trocar placement is, well, that could be lap chole or it could be an appendectomy. I'm really not sure, but it just kind of shows you. Again, they're going to put this one in first. Again, our setup, okay, might be a little different than the other picture, but it's the same. And then this is everything set up at the field. You can see the draping that you have to do, okay. All right. Cannulas and trocars, they're a little different because these are metal. Okay, I think they now do have disposable ones for robots, but I think I saw some, but for now, we're going to learn the cannulas and trocars for robotic. And if you're looking, these are metal. There's a short one and a long one. This would be for what? Probably, it says high BMI patients. This would be for gastric bypass, okay? And these are the normals. And you can see that they have plastic trocars for the cannulas, okay? So you do get those disposable, but these are not disposable. And that's it. Any questions, please email me. Let me know if you have any concerns, any questions about your flashcards and so on and so forth, okay? There we go.